examination of the hands, finger feeling. Perfect percussion, Margaret. And I must say that suturing you performed earlier was truly top-notch. However, did you know many do not have the dexterity you demonstrated this day? To assess these patients, you must know of examination of the hands, finger feeling. After washing your hands and gaining consent, expose the upper appendages to the elbows and provide a pillow. Now survey the hands, Margaret. Note any skin and nail changes, muscle wasting, swelling, or deformities. Observe the palms for wasting, Dupuytren's contracture, and clawing. Terrific, Margaret! Now inquire about pain before feeling both radial pulses. Feel for temperature of the wrists and hands before palpating for muscle bulk and tendon thickening. Now test sensation of the skin overlying the thenar and hypothenar eminences, followed by the first dorsal interossei. Tenderness as one gently squeezes the metacarpal phalangeal joints can be present in rheumatoid arthritis. Inquire about the pain once more before palpating each joint for synovitis and tenderness, whilst observing the patient's face. And be sure to palpate the joints themselves, Margaret, as many students simply feel the knuckles, which will not be tolerated. After bimanually palpating the wrists, including the styloid process, feel along the ulnar bulge of the arm until you reach the elbow, where you should inspect for rheumatoid nodules, psoriatic rashes, and gouty tophi. Next, we must assess movement, Margaret. Ask the patient if they can perform both conventional and inverted prayer signs. Now assess active movements at the wrist, recording that wrist extension tests radial nerve innervation of the dorsal forearm. Finger abduction should be tested to analyze ulnar innervation of the dorsal interossei, whilst adduction tests the palmar interossei. Fromen's test may also be performed to assess ulnar innervation of the intrinsic muscles of the hand. Now assess abduction of the thumb. Abductor pollicis brevis is a muscle of the thenar eminence and is supplied by the median nerve. You can also test other movements of this important joint to assess functional capability. Follow this up with Finkelstein's test for the Quervain's tenosynovitis. Nearly there now, Margaret, but you still have to fully assess hand function. Ask the patient to make fists and observe any deformities before comparing grip strength. Next, test pincer grip before completing the exam by asking the patient to do up a shirt button or pick up a pen and write a sentence. After thanking the patient and making her comfortable, re-wash your hands. Offer to examine the elbow and assess the neurovascular status of the upper limbs. Now present your findings concisely, Margaret. For instance, one may say that Miss Morgan is comfortable at rest and has obvious bilateral symmetrical deforming arthropathy affecting her MCP and PIP joints, yet sparing her DIP joints. She has ulnar deviation and a boutonniere deformity of the left index finger. She has dorsal guttering and obvious swelling over her wrists. Functionally, she has difficulty with her grip and consequently has difficulty with certain activities of daily living, such as holding a pen or doing up buttons. To assess her disease activity, I would now like to do a formal DAS-28 score. Margaret, that examination was certainly dexterously done. I'm sure you won't be tied up in knots the next time you're asked to perform examination of the hands, finger feeling.